orthopedics, of course, is dealing with the human musculoskeletal system or the neuromusculoskeletal system. And a problem, I think, with literature and people's understanding of fixing or addressing these disorders is the almost exclusive focus on restoring function and reduction or elimination of pain. And the way I see it as those are goals, but they are byproducts of the true goal, which is reversing the actual musculoskeletal disorder. That is, if you fix the problem, the pain will therefore go away and function to the system, whether it's through being able to sit without pain, roll over in bed at night without pain, not have numbness when you walk in your leg, be able to do athletics, whatever the function is that's lacking in that person's life, pain-free function, that will be restored as well. When it comes to the musculoskeletal system, there aren't that many parameters that we're actually dealing with. If you think about other systems of the body, I think there are much more kind of parameters, biomarkers, signs and symptoms that we're dealing with. The musculoskeletal system, I think, is more limited. The three primary things that we're looking at are joint range of motion, muscle strength, and to a lesser extent, muscle flexibility, but I think that's really overstated. And thirdly, nerve extensibility. And notice that we use different words. It's mobility for joints, strength for muscles, possibly flexibility, and extensibility for nerves, because they're different paradigms. It's not, I don't use those words interchangeably when I speak about medicine. With patients I may, because it's the word they use. But I argue that joint mobility is far and away the most important thing that we're looking at in musculoskeletal problems because of the prevalence, because that's the defining factor in most disorders that I find. And that means that if the joint's not moving well, you can see muscle weakness, you can see muscle tightness, you can see nerve tension, and the other way around is less common. So when I look up orthopedic studies and I see that the endpoints, the goals of the intervention or the research question is how much pain was reduced and how much function was restored, I think those are nice goals, like I said, but if you dwell on those as endpoints, you're not telling me if the disorder was reversed. I think the first question should be, was joint mobility restored to full joint motion? Was muscle strength restored or muscle flexibility restored? And was nerve extensibility restored? And because of those, the pain was reduced or abolished and function was restored, etc. If you read one of those studies and you don't know what the treatments actually mean, you won't know if those signs were restored. And I think you wouldn't know it as a layperson, especially because in many of these papers, I would say the majority, if not the vast majority of papers, they're not telling you the person had limited shoulder range of motion and flexion by 20 degrees, or the patient was lacking hip internal rotation bilaterally by 10 degrees. You're not learning the problems that would help you understand the disorder. You're just understanding this person had IT band syndrome and they couldn't play soccer, or they had pain with running at mile 3, which 2 weeks later was at mile 1. You're not really learning what was the mobility, what was the extensibility, what was the strength, and therefore you can kind of pair the intervention with actually changing those signs, those biomarkers. So those are the three main ones, and those are things that we focus on for the vast majority of patients. There are other signs such as poor balance, poor motor control, poor proprioception, poor coordination. Again, I find most of those are kind of secondary to the primary things that I mentioned of those three. You also see things kind of more nerve related like paresthesia, which is altered sensation, especially in the extremity if a nerve is affected in the spine. But you can see that with trauma to nerves as well. But my problem with understanding orthopedics, if you're reading the research, is that they're not focusing on reversing the disorder. They're focusing on pain and function, which again, to me are kind of benefits of reversing the disorder. An example in non-musculoskeletal care would be reversing type 2 diabetes, right? If it's diagnosed by an HbA1c that's elevated, if it's diagnosed by a fasting glucose or a fasting insulin that is elevated, then the reversal of type 2 diabetes through whatever intervention that's being used is not, does the person have less pain in her feet? Or does the person have slightly better kidney function or eyesight or whatever the sequelae of the type 2 diabetes is causing in that patient's body? Or the endpoint is not, can that patient walk longer? The reversal of the disorder is delineated by the biomarkers that define the disorder being reversed. HbA1c normalizing, fasting glucose, fasting insulin normalizing, or other glucose tolerance tests, other tests that people use that are standardized and objective. And I really think we need to think of orthopedics that way as well. We don't have biomarkers in the blood, like with kind of endocrine disorders or disorders that internal medicine deals with, but we do have really strong biomarkers with joint mobility. and muscle strength and nerve extensibility. I find another kind of problem in this arena with regards to that, however, because I think a lot of patients and clinicians, they are misunderstanding how much joint range of motion is normal. In the extremity joints, we can compare your right knee to your left knee, and that's a great litmus test to see if they're equal. In the absence of having two, so when we're thinking about the spine though, I think a lot of people are being told they have normal spine mobility when it's not their normal. Spine mobility and hip mobility and shoulder mobility to a smaller extent have variable findings in different people. There's a normal range and people can fall at different parts of that range. You could have 30 degrees in hip internal rotation and that's normal for you. Another person has 50. So to find if your normal range of motion has been restored, we really have to challenge that joint and just see how much we can get out of it. And we stop once we've done our thorough due diligence and we haven't gotten more range of motion out of that joint. So that's why I think there's a secondary problem with, if we're going to go by biomarkers of mobility, strength, and extensibility of nerves, I think a lot of people get the strength reliably correct. I think most clinicians will agree on a 5 out of 5 shoulder flexion strength test. I think most clinicians will agree on a knee extensor 5 out of 5 test or 4 out of 5 test. 5 out of 5 would be normal strength. I think that's more across the board agreed upon. I think nerve extensibility is quite agreed upon too. Lower extremity and upper extremity nerve tension tests are standardized and they should be normal and pain-free, and there's smaller variability in how far a normal nerve goes for a person. But that joint mobility piece, I really think we're not looking at making sure that people get their full joint mobility, especially in the spine, because if normal, say, has a range, that's quite wide, if it's on the low end, someone says, oh, you're normal, but maybe 5 years ago you were on the high end. And so actually achieving that normal range of motion for you would be getting significantly more. So I have a problem with orthopedics focusing on reversal of pain and restoring function and not focusing on objective, kind of more hard and fast rules or biomarkers of the body, if you will. And I have a problem with underestimating the role of joint mobility and how much people should have, because we're kind of too timid to really push joints to end range and see how much mobility we can get out of it. Because there are so many patients that, for me, their hip range of motion is normal. It looks good, but it's not their normal. And so getting that extra 5 degrees, 10 degrees, 15 degrees is the thing that fixes their problem. And that's why I said at the outset, so many problems I find are actually mediated by loss of joint mobility and restored by moving the joint into the direction it needs repeatedly over a course of days to weeks while we temporarily reduce or stop doing the motions that make the joint problem worse. Robin McKenzie proposed this diagnosis many decades ago. He calls it a joint derangement, a mechanical problem, if this is the case. If moving the joint in a specific direction resolves the disorder, I would call that disorder a mechanical joint derangement. Joint mobility has to be restored as a result. Strength deficits, all those other problems have to be restored for us to call it that as a diagnosis. This diagnosis, of course, is not really accepted in mainstream medicine, unfortunately, but it's what I find in 70 to 80% of people. But in conclusion, I really wish that orthopedics were more kind of standardized, more objective. And when I'm working with patients, I don't want to just get rid of pain or decrease pain. I want to present to them an idea of what the disorder is, what I think it is, my hypothesis, and prove to them that we've reversed it because we've written down, oh, you're lacking these different 5 normal ranges of motion: shoulder abduction, let's say, shoulder external rotation, neck side bend to that side, neck extension, and maybe shoulder internal rotation on the back. We have those written down. We have the strength problems written down. If there's a nerve problem or another problem, we have it written down. And if we've done our job at reversing the disorder, all those things that we've written down as signs and symptoms should be reversed.